Hi, everyone, and welcome back to Fit for Fellowship, Survival Guide for the First Year General Cardiology Fellow. I'm Megan.
And I'm Stacy.
And welcome back. We're going into the QA session now with Dr. Srivastava. So let's dive right into your questions.
Dr. Srivastava, also thank you so much for being here, taking the time. Your lecture was amazing, and I really, really wish I had that when I was a first-year fellow. So we're really grateful for your time.
Yeah, thank you, Stacy, and thanks, Megan, for doing this. I think this is great, and hopefully this stays for time to come. Boot camp of sorts done for every incoming fellow, and hopefully ACC does this across the country as well.
Yeah, thank you again, Dr. Srivastava.
Thank you. So the very first question is about the relationship between speed, flow, and power. So you had a couple slides that talked about changing speed, affecting power, changing flow, affecting power. I think the question was more, it's not ever the other way, right? You don't set a power, it's always the other parameters that affect your power. I think the question was more about the relationship with those three parameters. And then how speed and flow then inter effect.
Got it. Okay. While I start speaking, I think if you can give me permission to screen share, I just want to pull up that Lvad screen and then perhaps show the screen while I speak, if it works.
I think
not, no problem.
Let me know if you're able to. If not, I can.
Okay. Yeah, it tells me it's disabled. So that might be a setting. I think when you go to under participants or share screen and you say multiple participants can share.
Yeah,
Gotcha.
make host.
I have to make you a host.
Yeah.
All right. We should still. Okay. I think this.
Yeah, it works now. Yeah.
Good. Great.
Yeah. So you're able to see my screen now?
Mm-hmm.
Okay, perfect. So I think when you look at the Lvad console and screen, so you have a few parameters over here. You have pump flow, you have speed, you have pulse index, you have power. The only thing that the clinician, the Lvad team can actually adjust or change or do at any point is only the speed. So speed is the only variable on all these numbers that you see here that you can titrate, adjust based on a given patient and their hemodynamics. Everything else that you're seeing on the screen is a calculated or derived measure from the Lvad that's displayed on to us as a clinical team. So this example, we set a speed of 5,500. The Lvad knows, the computer in the Lvad knows, this is the amount of power or wattage I'm consuming to run the pump at 5,500. Okay, so then it gives you 4.5 watts. So that's what the power is. Then based off the power, it says, okay, if I'm running the pump at 4.5, my estimated, it's not true, right? My estimated flows are 5.3. So that's how the power and flow is derived. And then the only other variable left there is the pulse index, and that you can see on this screen. So then it takes the power and applies this formula to calculate what the pulse index is for that cycle and that beat. So that's how it gets to the pulse index. So as you can see, pulse index is derived from power. Power is a direct measure. Flow is also derived from power. The only thing we have control over to adjust is just the speed.
Fantastic. Thank you so much, Dr. Srivastava. The next question that we have is this fellow has heard that there is a recall on one of the Lvads. Which one is it, and what are some complications I should watch out for in these patients that have the recalled Lvad?
Yeah, I think so. As I mentioned, so currently the primary market share and Lvad manufactured in the US is the HeartMate 3 made by Abbott. There is the HeartMate 2, which is a prior generation Lvad, which still there are many patients out in the community with. So you want to be familiar with the HeartMate 2. The pump you're referring to for the recall, it's not exactly a recall. So HVAD, which is the pump that was made by Medtronic, is discontinued and no longer being made. So when you hear about these recalls, there was no recall per se that all these patients with any type of Lvad had to come back and now they have to have a sternotomy, you have to change out the VAD or any such thing. There were recalls related not exactly a recall, more an advisory of thoughts that there is a potential, a cable disconnect, double disconnect can happen, and patients can completely lose power, and the VAD might stop. And that's happened with more than one sort of pump at various stage in their development or in their use, rather. It's happened, with the HeartMate 2, there was certain advisory issued with the HeartMate. HeartMate 3 is actually going really well. But even with the HeartMate 3 early on, there was some concern with the outflow graft that is no longer a concern. And so not a broad pump recall per se, but risk for, I think what they're alluding to is the HVAD pump that is at risk for a pump stop, and a significant advisory related to that is something to keep in mind.
Fantastic. Thank you so much.
Great. So next question is, what is technically a normal speed? And when we're looking on echo, the person says, we look at opening of the aortic valve. How does that correlate with speed? Why is it that we want it to open intermittently?
Yeah, so it's a good question. So in terms of what is the optimal speed, it varies based on the pump that's used. So the HeartMate 3 pump, roughly the speed usually varies around between, most patients clinically, the operating range tends to be anywhere between 5,200 and 5,600. If you see this on this slide, we see the median is 5,400. But most patients, if in clinical range, fall usually somewhere in the 5,000s for the HeartMate 3 pump. The HeartMate 2 prior generation pump, it's between 9,000 and 10,400. And this 5,000 here doesn't equal to 5,000 there. It's just different numbers. It's not sort of like an automobile speedometer where 100 miles an hour on one car equals, it is 100 miles an hour. Each pump has sort of a different speed range that they've picked. And that's just based on sort of the pump itself. HVAD, which is so that operating range is between 2,500 or 2,600 and 3,000. So you just want to be familiar. Okay, HeartMate 2 is the highest. It's between 9,000 and 11,000. Then is the HeartMate 3 in the 5,000s. Then is the HVAD in the high 2,000s and low 3,000s. So that's how these pumps are set. That's how their operating ranges are. And the way you pick the speed, as you mentioned, so when we do an optimization, usually, most programs, it varies a bit program to program, but you do a right heart cath about it could be 6 weeks, or it could be 3 months after after a VAD implant, when they're well sort of settled and recovering. You bring them to the cath lab, you put a PA catheter in, and then you ramp up the speed to see what the right-sided CVP and PA pressures are doing, and what the left-sided wedge pressure is doing. And then you want to adequately unload the left ventricle so you find a good wedge filling pressure on the left side. And you want to make sure you're not overfilling the right side with cardiac output and putting stress on the right side. So you find that balance from a PA catheter between the left-sided filling pressures and the right-sided filling pressures, and then obviously the cardiac output that you estimate of a FIC to make sure you're getting adequate perfusion. You can also do that by echo. So after we've done that, usually a baseline right heart cath follow-ups, we don't always do frequent right heart cath, but we can do by echocardiograms, where we're looking at, okay, what is the size of the left ventricle? What is the size of the right ventricle? Is the septum in midline? So to achieve sort of optimal Frank-Starling curve. And we look at the aortic valve opening, and that goes to the question about why do we pick every third beat or every fourth beat for aortic valve? And partly this was based on, ideally, so the patient's ventricle is thick enough that they can't generate enough force to push blood through the aortic valve, which is why they're getting a VAD in the first place. And if they have a VAD, you much rather have most of the flow go through the VAD, because that's why they have a VAD. And so you can get good cardiac output, You can lower the filling pressure. So you want to increase the VAD speed to suck blood out from the left side. And also, especially in the prior generation pumps, when you ran the pump speeds much lower, there was a higher risk of thrombus or clot forming in the LVAD. So there are more than one reason that you want most of the blood going through the VAD. And that balance is where then you end up picking every second or every third or every fourth beat of aortic valve opening. And primarily because what we're trying to do is also not have stasis of blood in the aortic root. So you have the outflow graft, which is in the proximal ascending aorta, and you have blood there, and if the aortic valve is shut, they can be stasis. And there's been sort of computational three-dimensional studies showing that area, blood, there tends to be blood stasis, leading to thrombus or clot formation. So having that washout with the aortic valve opening every few beats decreases the risk of clot formation as well in the aortic valve. So it's a sort of a twofold. One is optimal hemodynamics, and two, decreasing clot formation in the VAD and decreasing clot formation on the aortic side.
Thank you.
Excellent. So the next question is in regards to thrombus. So what changes do I see in power, speed, and PI event with thrombus of the LVAD?
Okay, so that's a good question. I'm going to go back to this flow sheet over here, and we can walk this back. So the question is thrombus, right? So one thing you want to keep in mind with thrombus is it's not a binary thing of yes thrombus, no thrombus. It could be a thread-like strand like thrombus. It could be a big occlusive thrombus. When you have an occlusive thrombus, you're going to see what you'd expect more classically. Now there's not enough blood going through the pump. Depending on the patient's intrinsic LV contractility, the patient can go into heart failure, and they have heart failure symptoms. So that could be one extreme when you have a significant occlusive thrombus in the pump. Other than that manifestation of heart failure symptoms, if a piece of that big thrombus also went to the brain and caused a stroke, you can also see heart failure and stroke at the same time, or within that window. Short of an occlusive thrombus, and then you go lower down, you could have a strand-like thrombus, you could have a non-occlusive thrombus. And the way we pick this up, so even if there's a little thread-like thrombus in a pump, what happens is that the pump is not working optimally. So one, you have turbulence of blood flow as it goes through the pump, because it's no longer that smooth surface because of a tiny little blood clot in there or a thread-like thrombus. What that does, you have then breakdown of blood cells. And that's why what we're looking for, even before we get to this occlusive thrombus, we'd like to catch it. That's why we screen these patients on a regular basis, and we're looking at LDH, which is a marker of hemolysis. So if their LDH is trending up from baseline, we know, okay, they're forming a little some thrombus. That's in the differential. There are other reasons people can get LDH in a bad patient, like aortic regurgitation. Anywhere where you have turbulent blood flow can cause LDH going up from hemolysis. Keep in mind, there are different isoenzymes of LDH. You could have muscle breakdown that can cause the LDH to go up. So it should fit the right clinical picture. And you can also order an assay, LDH isoenzymes, to look at the different types of LDH and see, is it from the liver, is it from a cardiac tissue or skeletal muscle tissue, or is it hemolysis derived for that kind of thrombus. So now if you take that scenario where you have a non-occlusive small thrombus, patient might be completely asymptomatic because the pump is still working fine, they're not in heart failure, their urine looks clear, and all you might pick up is LDH on a screening lab. Now, as that thrombus can increase a little some in size without being occlusive, what it can do, you can see fluctuations in power, because, and if you think about it, you'd expect, okay, intuitively you're thinking, well, there's a thrombus in there, there's blood not going through, the power is going to go up. But that only happens in a fully occlusive thrombus where the pump is really trying to work hard to get blood through the pump. But if it's in the middle, not a full-on occlusive thrombus, not a thread-like thrombus, but a mini thrombus of sorts. So then what happens, if you think about it, there's actually less blood flow going through the vat because of the thrombus, but it's not large enough that the pump is trying to work hard. And keep in mind, the LV is still squeezing. So, well, the pump is doing a little less work. That blood is now pushed out through the aortic valve. The pump doesn't know it has a thrombus. All the pump is thinking, oh, I have less blood flow going through me. I just need less current, and it uses less power, you know? So you can see normal power, you can see reduced power usage, and you can see high power usage depending on the spectrum and size of thrombus that the patient has. And now you can apply that same concept, because remember, I told you pulsatility index, or PI, is calculated off the power. So depending on what power happens in that thrombus patient, accordingly, your PI is going to fluctuate. And so it depends on the size of the thrombus and intrinsic contractility of the left ventricle, and is the aortic valve open or suture tight, to dictate that sort of interaction and relationship between blood going out through the aortic valve and blood going out through the vat. Yeah, so it is not just one scenario. You can see power being, like I said, all three can happen: normal, going up, going down. Same thing can happen with PI, no change, going up, going down. You just have to, so what makes you suspect? Okay, on a screening lab, you might see LDH. If they had hematuria, that's the most significant thrombus, usually you'll see it. Far extreme, clinically, they might be in heart failure symptoms. If they don't have any of that and they just had an echo done, you might see currently the aortic valve opening maybe every beat, and maybe in the same patient at that same speed on a prior echo, it was opening less frequently. So it tells you, okay, well, if it was opening less frequently before, why is it opening every beat now? And that tells you blood's not going through the vat. It's, for some reason, it's going through the aortic valve, and should make you think of thrombus as in the differential.
Excellent. Thank you so much, Dr.
Yeah.
Srivastava.
Thank you for answering that so thoroughly. The next question is, with CPR, do you need to change the pump of the speed?
Yeah, so with CPR and sorry, what was that?
No, I just misspoke. I meant speed of the pump.
Yeah. So if you look at these, so with CPR, usually what you're doing is not changing the speed at that given time. Now, depending on why they went into CPR, right? I'll give you one scenario. There's the post-op patient, and they're in their ICU bed, and maybe they're profusely bleeding out, and they have no volume. And because of no volume, they might have gone into cardiac arrest, and they're getting chest compressions, and you place a quick echo probe, and you see the LV is completely underfilled because of volume. So while you're doing volume resuscitation, you'd be like, what good is a VAD speed being high? There's no volume in the ventricle. You could turn the VAD speed down while you're resuscitating with volume. Another scenario, if the patient went into cardiac arrest because of hypotension or RV failure, and the left side is underfilled, that would be another scenario where you're going to change the speed of the pump. So speed of the pump in CPR, you're usually going to change if based on the loading conditions, that, because the pump is preload and afterload dependent, dependent and afterload sensitive. So if there's no preload, you don't need that much speed. You could take the speed down, resuscitate. Otherwise, you're going to have the alarm going off, telling you low flow and PI events. So that's really why you're adjusting the speed in a VAD patient who you're doing CPR. It truly depends on the etiology and why the patient's having CPR. Is it arrhythmia? Is another scenario. Usually arrhythmia, still the VAD has enough volume and blood. The ventricle has enough volume and blood in it, and it's sustained. But sure, if they go into rapid AFib at a high rate and they're underfilling the left ventricle, then you're going to run into the scenario where you will probably be turning the VAD speed down.
Excellent. Thank you so much. The next question has to do with the difference between HeartMate 2 versus HeartMate 3. This person was asking, why does the HeartMate 2 patients have more PI events than HeartMate 3?
Yeah, so that's a great question. I mean, so the fundamental So there's two differences in terms of the pump itself. So this slide here shows you the HeartMate 3. So the technology is extremely different. The name sounds very similar. HeartMate 2, it sounds like an iPhone 2, iPhone 3, but this was sort of the earlier generation of iPhones where there was a big difference, right? One generation of iPhones to the other, and it's not just about a new color or some new little features. This was drastically different pumps. The HeartMate 2 and HeartMate 3 are completely different pumps. So the HeartMate 3 shown on this slide is, the technology is referred to as magnetically levitated, sort of centrifugal-like pump, where you don't have a bearing and you have sort of, because the bearing used in the Ruby bearing used in the prior generation of VADs was really thought of as a big reason why patients were having thrombus form in the pump. So getting rid of that and having this maglev technology has really helped tremendously in terms of decreasing thrombus rates arising from the pump. So one difference is that. So it's sort of, I wish I had another picture to show you over here. This shows you a little deeper view, but you can Google and you can see how the inside of the pump looks extremely different. Now take that, and now here you have what this is showing you is the HeartMate 2 pump. So you can see how the other one was round and spherical, and this one is more like an axial, like a spindle. And here, this red is what is like a bearing, so you have, and you see as this pump is running, so it's turning along this axis, sort of like an Archimedes-like screw, and then basically you have blood being pushed from one end to the other end. So completely different pumps, completely different technology, and that's just the pump itself. Then there are other differences. For example, in the HeartMate 3, a lot of the system, the computer technology sits in the pump itself, whereas in HeartMate 2, a lot of it was on the controller itself. So there are other differences as well. The key thing to keep in mind, this is an axial flow pump. Another example of this in the temporary mechanical space is like an Impella axial flow technology. And if you think about centrifugal, the HVAD is a centrifugal flow technology. ECMO pumps are centrifugal technology, So as long as especially at the first year level, if you know that, hey, these pumps are very different, and why that becomes truly important is, we're getting better outcomes with this technology, but also what you'll see in your second and third year, you get a little bit more into detail, is something called an HQ curve, which is sort of, the power consumption of the pump, the operating range, and the flow given out by the pump. Those characteristics are very different from pump to pump as well. And that's where the engineering piece comes into, we think the HQ curves with this pump are more favorable for certain in the clinical setting. And that's the mechanics that we get into probably later in your fellowship.
Thank you very much, Dr. Srivastava.
So this is the last question. And so the question is, under what circumstances does VAD have to come out and be replaced?
Yeah. So under what circumstances the VAD has to come out, right? So I think we went through a few different scenarios. So if it's a thrombus, no matter, obviously, if it's an occlusive obstructive thrombus, there's not much you can do other than exchanging the pump and putting a new pump in. There have been studies looking at, whether you're lysing the clot, putting a catheter-directed TPA, in some cases systemic TPA, but that generally has not had good outcomes or success. Sure, you have case reports here and there where it's worked out, but usually, when a patient has an obstructive thrombus, it's pretty much you have to exchange the pump. Short of an obstructive thrombus, if they have a non-occlusive thrombus or a smaller thrombus, we usually try to, depending on the clinical setting and how they're doing, try to aggressively anticoagulate them to break the clot, break the thrombus, and see if we can get by without having to do a pump exchange. So the big one is occlusive thrombus. A non-occlusive thrombus that's not resolving and then especially causing clinical heart failure symptoms. And then you get into infection. If they have an infection that's in the pump itself, you have to consider, is this a patient who could go to transplant? Can I suppress with antibiotics, get this patient a transplant, not a transplant candidate? Then probably have to exchange the pump over there. And then the pump failure, mechanical pump failure or electrical pump failure itself is extremely rare. But those are other scenarios where you would consider or be exchanging the LVAD pump.
Excellent. Well, thank you again, Dr. Srivastava. We really appreciate it. Excellent presentation. Very, very practical to, what we use on a daily basis with the LVAD. So that's excellent.
Thank you so much.
Yeah, no, most my pleasure and truly an honor. Thanks for giving me the opportunity to share or at least give you guys an overview on the workings of an LVAD. And the key thing to keep in mind as a first-year fellow, you're not trying to learn at all. You just want to get an idea, an overview, and it's truly sort of just a stepping stone and foundation to, know what a VAD is, know the basics, and then as you go through your years of fellowship, you're going to learn more and more. It's not something you need to absorb it all in month 1 or month 6, Yeah, thank you again.
Definitely. Thank you.
Thank you.